I don't know if any of you have had the following experience. You ask your dearly beloved children to go upstairs and tidy their bedroom. And then you ask your children, after the said bedroom has been tidied, whether they consider the room to be tidy. On the one hand, the said children will say, "This room is tidy." My experience is that the adult parent rarely agrees. And so the same bedroom can elicit quite diametrically opposite opinions. And so we thought it would be very interesting to have the same set of circumstances, that is commoditization and access, if you like, to necessary care, the economic argument considered by an expert economist and by an expert person with disease. And so we have the economist and person with arthritis view. And Olivia and Peter were kind enough to accept the challenge to look at the same reflection and give their own quite unique and distinct views. So maybe I could ask, first of all, Professor Olivia Wu to come to the podium. Olivia is actually one of my friends and colleagues who works in the University of Glasgow. Olivia is a health economist of international repute. We're very fortunate to have you with us today, Olivia. Thank you very much for joining us. We look forward to hearing your discussion.
Thank you, Ian. So thank you for inviting me to talk to all of you today. I must say, when I first got the invitation, I was a little bit nervous. Often in meetings like this, I find myself as a health economist being the lone voice in the room. But today is really quite different and quite refreshing. From this morning, very early on, I hear people talking about burden of disease. I hear people talking about cost of illness. And then from the 3 workshop recommendations, there were talk about value for money. You're all speaking my language, so I'm thinking actually, you know, you are all really already thinking like a health economist. So what I'm going to say in the next 10 minutes may just be what you already know. So I'm going to try and talk a little bit about health economic benefits of participating in the labour market for people with chronic conditions from my perspective. So what is a health economist perspective? Now, we all live in a budget-constrained environment, and I think this is a really, really nice representation of what we're dealing with. We have a constrained budget, and it doesn't matter whether we stretch it a bit further or not, it's always constrained. So when investing in healthcare in this kind of environment, it is inevitable. There will always be winners and losers. When you're investing in new technologies, new interventions, new diagnostics, in a sense what you're doing, you're displacing something else from the system. If you're investing in one thing, you have to stop doing something from current practice. And that's just the reality of a constrained budget. So there is an opportunity cost to everything we do relating to healthcare investment. And what health economists want to do is to maximize health within this given budget. How do we get the maximum benefit out of what we've been allocated? How do we prioritize what's important? We talk about outcomes that are important to patients, but there are a huge variety of outcomes. There are clinical outcomes, there's outcomes to well-being, there's outcomes related to work. So how do we prioritize these outcomes? And how do we measure? And more importantly, how do we value these outcomes? Are they all equally important to you as individuals, or are some more important than others? So I've looked at some of the evidence in the context of RMD, and this is a very recent study looking at estimating burden of rheumatoid arthritis, looking at data from 1990 to 2017. So it's a really, really nicely done study, very recently published in the Annals of Rheumatic Disease. They looked at, they estimated prevalence and incidence of events, and they looked at burden measured by disability-adjusted life years, DALYs, and I think that was mentioned earlier today. And this is typically how burden is measured. So DALY represents life years lost plus life years lost due to disability. and this is how generally we estimate burden. But one question I'd like to ask you to think about is this all? Is this really representative of all the burden in chronic disease and also in RMD? Is this the best we can do, or should we be doing better? This study also looked at the association between burden and other factors such as age, sex, and socio-demographic index, healthcare access and quality index. So these are all things that might have an influence over the estimate of burden. And what the study concluded broadly is globally that prevalence and incidence of RA is increasing. It has increased from 1990 to 2017, and age-adjusted DALYs has decreased from 1990 to 2012, and then increased again following that up to 2017. And that the UK has the highest age-standardized prevalence and incidence rate in 2017, and countries like Canada, Paraguay, and Guatemala show the largest increase in age-standardized prevalence and incidence rates during this period. So very comprehensive set of data. But what's really interesting in this paper is this graph that they've shown. And this, this is a very pretty graph and probably quite difficult to follow. So let me try and explain to you what this is showing. So along the bottom line, the horizontal axis, they've plotted socio-demographic index. So the lower the socio-demographic index, which is on your left-hand side, means represent developing countries, so poorer per socioeconomic status. And on the right-hand side, if you go up to 0.9, is where the developed economies are. So we in Western Europe are generally on the right-hand side and developing countries on the left-hand side. And on the vertical axis is the age-standardized DALY rates per 100,000 population. So this is the estimate of disease burden. So and then the black line, the black squiggly line in the middle, is the overall global age-standardized DALY, so the burden according to the socio-demographic index. Now, what's interesting is it is not linear. So in countries of developing economies, it does not equate to those countries having severe burden as estimated by DALYs, and vice versa. And some countries do better, sitting above the line, and some countries don't do as well, sitting below the line. And the colored lines are basically data from individual regions from 1990 to 2017. So you can see some countries, the burden's coming down, but in other countries, it's relatively flat, and in some, the burden is going up. Again, there is no clear and easy explanation for this. I mean, part of it could be due to the quality of the data, but there's a lot of other factors influencing this. So on the right-hand side, where the high economic economies are, the circle on the top is representing North America. So the burden in North America is actually going up the way in terms of DALY rates from 1990 to 2017. So in such a high economy, they're actually not really reducing the burden of RA in the population. And on the far left, the pink squares you can see is Eastern Africa. So interestingly, the burden over this time period is actually coming down, but it's still above the global expected burden. So, it's actually quite interesting because one of our teams in the university is actually looking at the burden of arthritis in Tanzania. So it's relevant to that zone. So I thought that this is really a very interesting picture of our burden in relation to socio-demographic factors. So socio-demographic factors here does not simply represent the GDP of the country. It takes into account education levels and also fertility rates and so on.
So we look at burden, we also look at cost. So health economists, of course, are interested in cost. And this is data coming from a piece of work that was done by our team recently, looking at all the cost of illness studies out there in rheumatoid arthritis. Now, in cost of illness studies across the world, across different health systems, it's really difficult to make direct comparisons across these studies. But typically, what you would expect to see is a measure of direct and indirect costs. So direct costs, typically, we talk about direct medical costs, so the cost of drug treatment, the cost of hospitalization, the cost of monitoring and managing your diseases. So these are costs that are borne by the healthcare system. You may also have direct costs that are relevant to individuals, so cost of informal care, cost of transportation, going to a clinic regularly, and so on. So in this graph is represented by the blue charts. So you can see that it varies across the different studies, but it is quite a substantial proportion of cost of the total cost in many of those studies. Now the red bar represents indirect costs, and these are costs that are associated primarily with absenteeism and productivity. So in these studies measuring the indirect costs, what they typically do is to measure the loss of productivity. So individuals suffering with chronic conditions who are unable to work or have to retire early would have cost implications. So in some of these studies, they were able to demonstrate that this is a substantial proportion of the cost. And what would be really good is if we can have a more standardized way of measuring these costs so we can truly understand what contribution indirect and direct costs are making towards the overall economic argument. And the green line in the middle is basically the absolute cost that was calculated by that study. So generally, it sits between 10,000 to 30,000, and this is in US dollars. And there is a spike in the middle, there's an outlier from a Norwegian study. But I think that's fundamentally due to how they measure the cost in that study. So costs are important components. So as I said, direct costs we can think about costs that are related to medical care and to the individuals. And indirect costs, we can think about costs associated with sick leave, loss of productivity, presenteeism. Now, presenteeism is also something very relevant. So those who are suffering from chronic conditions but continue to work with reduced health may lead to reduced productivity. So even though they're not removed from the work environment, they may not be producing the same amount of work as they would otherwise. And then we also have disability pensions and early retirement. Now, the important thing here is whose perspective are we interested in? So typically, when we think about investing in healthcare, we often just adopt the healthcare payer's perspective. So this speaks to the separate budget that we talked about earlier. So if we only think about the healthcare budget, then some of these components that I talked about do not get taken into account into the equation. But these are all relevant and very important. So should we be thinking about just the healthcare system's perspective? Should we take into account patient's perspective? Should we take into account government perspective, a societal perspective? So I think this is really important. This has huge implications on costs, but it also actually has implications on benefits as well. Now, this is a report that I think most of you are familiar with, Health at a Glance Europe 2016. And in this report, they showed data and concluded that chronic disease may have important labor market impacts, and they showed impact of reduced employment, early retirement, and reduced income in people suffering with chronic conditions. And they show that people with one condition compared with no chronic conditions, there's a huge difference. And this difference is even more amplified when you have multiple chronic conditions. And so if we think about the impact of loss of productivity,
as I said to you earlier, we looked at those cost of illness studies that look at indirect costs. And typically, they look at loss of income, loss of productivity. And this is a really, really novel study that look at these indirect costs in an even broader perspective. So lost productive life years amongst Australians in the age of between 45 and 64 years from 2015 and projecting this cost implications to 2030. And this is done in a simulation model. So the first row here is loss of income, which is typically our productivity loss. But what they also calculated is extra welfare payments that governments are responsible to pay out for people who have to stop working. And also the loss of tax revenue that the government could be gaining if they were still working. So this is a really interesting way to look at this from a government's perspective as well. And we rarely see this in looking at the economic implications. This is a really broad perspective. And if you look at 2020, this is in Australian dollars. The loss of income is 15,277, and this is in millions. So if you convert this to euros, this is approximately over 9 billion euros. So the costs are substantial. So as a result of that report in 2016, this is some of the recommendations from the European Chronic Disease Alliance. And I think you're familiar with it because I think EULAR has signed up to this as well. And these are the 4 recommendations of chronic disease and work. And this is very much in line with a lot of discussions we've had today. We talk about investment in prevention and early detection of chronic disease. There seems to be some concern about how much should we be paying for prevention? How do we convince our policymakers to invest in prevention? And I think for anything in investing in healthcare, it's got to be cost effective. So whatever we invest, we should be getting appropriate amount of returns from that investment. And thinking about the short-term perspective, in some of the preventative strategies, there are short-term and long-term benefits. So what we might want to think about is to quantify these benefits in the short term and in the longer term to try and convince our policymakers to make that investment. The integration of primary and specialist care, so a more integrated approach, again, that's what we discussed. And developing policy frameworks and incentives to support work and also educate employers on the issues of chronic diseases. Now, all these things are what we can think about as complex interventions. We can invest in these areas to try and improve in these areas. But to convince policymakers to make that investment, we need good evidence, we need reliable evidence, and we need to show that this investment is worth money, is value for money. So what health economists are good at doing is we're good at weighing health and economic benefits. And we do this within a health technology assessment framework. And I think Ian talked about health impact assessment, which is very much in line with what we're doing. And in this kind of framework, it is important to think about the multidisciplinary process. So not just the clinical implications, but well-being, social, economic, organizational, and ethical issues all needs to be packaged within this evaluation and this argument to make it convincing for our policymakers. So going forward, these are things that I think we need to think about in order to develop effective health policies. Which policy, which intervention? Because there are different things that we can do. So what are the options? And for whom? Who should we be targeting? Who are the most effective population to target? And how do we implement it? What are the trade-offs for all these different options? Whose perspective should we be adopting? Historically, it's the health service perspective, but is that enough? Is that relevant? What about the people suffering chronic conditions and their carers and their families? Because there are spillover effects. Benefits to employers and to government, not just costs, but also the benefit side. So benefits, we talk about health-related benefits. We talked a lot about quality of life. We're historically interested in extending life, but what about the non-health related benefits? What about capability, the ability to do things, to continue to do things that are important to you in life? Workability, the ability to continue to work. And again, for whom? Is it just for the individuals suffering chronic conditions? What about the carers and the families? And finally, also the cost, which is in line with the benefits that we need to think about. So overall, I think what we need to do is to develop health policies that address multidimensional aspects of benefits and costs. We need to look at them all together. It's like when we talk about chronic conditions cannot be looked at in isolation. It is the same when we think about benefits and cost, and also multiple perspectives, a wider perspective. And if we're able to achieve that, then it will be a sustainable health policy for the future. Thank you.
Thank you very much, Olivia. And now to the patient view directly, I would like to invite Peter to the podium. Here he comes. He was giving me a hard time. Some of you may have noticed the demise of Scottish rugby, those of you who follow that game. We fell to the mighty Japan, leaving Ireland to play the All Blacks next week. Those of you who are into the game will know that that was a very bad thing that Scotland did to Ireland. Go easy on me, Peter. Go easy.
Yeah, I'll go easy on you, Ian, and I'll go easy on everyone because luckily for you, with another coffee break coming up, 90% of what I'm about to say has probably been touched on already today, so I'll be able to fly through all of this. I will try and not fly through my speech because I'm aware, being Irish, I do tend to talk quite fast, and with English not being your first language for many people here, it might be harder to understand. So I'll try and slow myself down and make sure I'm understood. It's interesting. You had Teresa this morning give you her own example of a patient perspective and what it means to her and the impacts it has on her own life of living with a chronic condition, living with an RMD. And just as an impact, you know, these are some of the figures that I've come across in recent years, looking at years lived with a disability, and RMDs are way ahead across Europe of the length of time that we're living with. It's cradle to grave, as been mentioned before today. Incidence of chronic diseases now, new cases per year. The green line there is RMDs, so just beaten out by digestive diseases. But again, new cases per 100,000, it's right up there. We're an aging population as well, so again, those incidences are going to keep rising. We've got to keep something in mind that the number of us living with these chronic conditions, living with RMDs, is going to continue to rise, and we're going to have to make sure that we're doing something that's going to manage it and keep an eye on it. When it comes to work, this is something that I've been very passionate about since I had to leave my employment 8 years ago. I was a full-time barman, and I was quite good at it, and I enjoyed it. As an Irishman who's working behind a bar, you have to talk to people, so it was quite an easy job for me, as you might have gathered. But nobody flies a barman around the world or around Europe to talk to people and explain what's going on. So since I got arthritis, it's been great. I've flown around Europe talking to people about it and telling my story. But when you look at this employment rate for people aged 50 to 59, it's a bit ahead of me at the moment, but it's to do with what was spoken about earlier, chronic conditions. If you look there, the first line is for no chronic disease and the employment rates across 14 countries about what they are. You add in one chronic disease, the employment rate drops a little. But you add in that second chronic condition or more, that's when the employment rate plummets. And that's what's been said before. With inflammatory conditions, I have rheumatoid arthritis myself. You add in inflammatory conditions, the comorbidities, the other conditions that live alongside it, all of a sudden that makes it more difficult and more difficult to stay in employment or to return to employment if you're forced to leave. So this is something that we all have to be aware of, and this is something that we have to consider when we're working at it. The work-related concerns for people associated with having an RMD. This is something that the reasons why people want to stay in work and the reasons why people want employment. It's not just a case of having money. It's not just a case of having that. It's having a sense of the psychosocial benefits of work. It's the psychosocial benefits that brings. if you look at the two biggest points here, it's nearly over 60%. If you look at the orange and the grey there, it's about not being able to carry out my work responses adequately and losing my job. They were the primary concerns for people in employment. When I worked in the pub, that was the two things that I worried about. I worried about presenteeism, was mentioned there by Olivia. For the last month when I worked in the pub, I used to go in on a Wednesday and we were supposed to clean out the barrel stores, we were supposed to clean up the bar. It's the first time I've admitted it on camera, so if Alan is watching in Harry Burns, I apologise. But I used to go sleep on the stools. My colleague, the dearly departed Tony, used to do all my work for me because I was in there but I wasn't working. I was doing nothing.
Yeah.
That's presenteeism. That's being employed but not actually doing your job. So I was afraid of losing my job and I was afraid of not being able to carry out my responsibilities adequately. That led to me losing my job. And that's what is important. Again, looking at the sick days, the number of sick days that people take around Europe based on their chronic conditions. No chronic disease, they're quite low. One chronic disease, you might get away with it. You might be in a position that you can manage it and you might be able to get in and out of work. You add in that second condition, you add in that second chronic disease, autoimmune disease that I have, inflammatory condition, all my systems are affected, everything is in one, all my organs are impacted, so that's where I am. You look at all places around Europe where that second condition kicks in, you're suddenly looking at maximum sick days. The figure on the right, it's been mentioned before, I think it's gone up now to 2% of GDP spent on disability and paid sick leave. So it's a massive impact from the economy side of it, but it's more importantly from the personal impact of having to take those sick days. The importance of being seen soon and the importance of our whole message around don't delay, connect today. If you look at this graph here, this is the number of sick days you take up until the time of treatment starts. So the treatment starts in the middle there where that arrow is, and the sick days increase and increase and increase right up to the point that your treatment starts, and then your sick days begin to decrease and lessen because you're actually on your treatment and that begins to take hold. If you can imagine somebody who doesn't get treatment in time, they're going to push out that treatment starting, they're going to take more and more sick days, and they end up having, and that's going to impact on their job capabilities and whether they're even kept in a job, because they may not be fired, but they may have to be forced out of a job because they can't be kept on forever if they're taking more and more sick days. So it's something that we all consider. And as employees, when I showed you that graph earlier, that's the fear that we have, is losing our job. So we have a fear for that. So maybe we don't want to take so many sick days, so we force ourselves to go in. Then we have the problem with presenteeism. So it's not actually the condition that causes us to lose our job. It may be the fact that we're not adequately doing our jobs. So it's all things that impact on us. Tiring or painful positions at work. This shows us the different impacts that we all have on that. And when I was working in the pub, I was on my feet all the time, I was carrying heavy loads, I was doing things like that. So that was all tiring, painful positions, but that goes across all sorts of different areas. It's across nursing, it's across any job that involves you being on your feet or carrying or doing anything that can lead you, even sitting at your desk for too long, you can be in a painful position, that can be painful for you. So we all have to be very aware of this, and the amount of people for the prevention that we've spoken about before, we have to be careful that we're not causing a problem down the line for ourselves by forcing people to do this. So the early and timely diagnosis is vital that we're going to have to do. This is the Irish situation that I'm a part of now as we stand. There's 7 million days in absenteeism. Half of the total in Ireland of all days in absenteeism are down to R&Ds. 750 million is the cost each year, and 295 million is paid out in illness benefit each year for people that because of R&Ds. Arthritis Ireland estimated the lost productive time is 1.6 billion, and we're part of the Fit for Work coalition. What's that? That's our way of trying to get people to improve employees' ability to work with RMDs, reduce the impact of MSDs on workplace absenteeism, and contribute positively to getting Ireland competitive again. Contributing positively. I'm a single employee, I'm a single person, but I want to do my best for the country as well. It was mentioned by Olivia there about on one side you have the cost of paying out benefits and the cost of that to a country, but on the other side you have the loss of a tax take and everything like that. So I'm aware of it. I'm just a patient. I'm just a single person, but I'm aware that that's what it is. So if I want to do that, there are other patients like me who care about it and want to make it better. So we all want to do that. Across Europe then, we've seen these figures already. 80% of the population we've affected by an RMD at some time in their working life. 49% of work-related disorders in Europe down to RMDs. As I say, you've seen a lot of these before, the facts and figures down to the bottom there of 2% GDP each year accounted for by the direct costs of RMDs. The impact, as I say, significant associated costs. It's all the different things that for health costs, social welfare, employment costs, the different employers and different things like that, how much it costs for them. The increase in absenteeism. I left work and I was taking sick days, but then there was also the increase in presenteeism. So I was making myself available for work, but I wasn't actually working, I was just there. The loss of productivity then, the pub that I was working in wasn't doing as well because it wasn't as ready for work as it should have been on those nights that I was there. And the reduced employee engagement and morale. I didn't enjoy going into work, I didn't enjoy it. I was really good at my job, as I say, but I didn't enjoy going in because it was a chore, it made me feel worse, and all I was doing was coming home for a break and to relax. I used to just go home, sleep, go back into work, and I hated it. And I came to hate the job that I'd loved so much and I'd done for about 12 years at that stage. You also have the higher staff turnover, the recruitment and training costs. It was mentioned a little bit earlier about people having 30 years experience or having 30 years left in their careers. Why, when you're paying for education, for university, for all these things to train somebody into a job, would you then just let them go and you lose all that experience and lose all that? It has to be done. It needs to be paid for, and you need to consider it. The direct costs have already been covered by Olivia there. I won't go through all of them. You know exactly what they are. What I will go down to, though, is the personal costs. The personal costs are not just the things that go with having to drive yourself to the hospital or things like that. I lost relationships. I lost friends. I lost material wealth. Lost self-esteem. I lost self-confidence. I lost all those things that can't be really measured in tangible things. They can't be measured in money. They can't be measured in things like that. But they're personal and they mean a lot. And when you lose all of those things, your ability then to have the confidence to come back and to do it again and go back into the employment and go back into the workforce, that's where it becomes difficult. So that's why it's needed to make that timely and early diagnosis, that timely and early engagement with the medical service. That's where you need it, because it's the personal impact of it, that you believe that you're unable to do it. You believe that you're not able to succeed and be able to produce good work. Whether it's in a pub, whether it's in an office, no matter what it is, you believe that you're unable to do it. The economy impacts. As I said, I've gone through some of those, and Olivia's gone through some of those as well, the loss in tax revenues, etc. These are the ones around the individual and family as well. So you have the loss of earnings essential for material well-being, increases poverty in society, but it was the loss of identity that really affected me the most. It was the loss of who I was, what I did, and if we don't have that as a patient, and I've heard it thrown about today, am I a patient? Am I a person living with arthritis? Am I a client? Am I what? I don't care. I think everyone's claimed it. I don't care what you call me, just not too early in the morning. Okay? You can call me whatever the hell you want. I can be a patient or whatever. That's fine. What I care about is that you focus on me. When I'm with the doctor, when I'm with the plan. If you're a politician, if you're a policymaker, if you're a stakeholder, I want you to think about me. Call me a patient, call me a client, call me whatever, but focus on me and the people like me and my cohort, and think about what impact it's having on me, because that's where we go. Last year, we launched in Ireland something called the Model of Care. And I'm sorry I'm delaying you from your coffee, but I'll just be 2 more minutes. The Model of Care for Rheumatology in Ireland, I was asked to speak at the launch of. Very good policy, very good thing that was brought in. The plans for this is to be patient-centred, provide better outcomes, Actively manage patient pathways so that you know exactly where you should be, where you should go, what you should do. Develop services at community, hospital level, and integration between the two. A key challenge is that interface. So what we're talking about, getting people to work together, and how do we divide that up, and how do we make it possible to work? That's what we need to manage, and that's a very important point. It has to be applicable to the existing Irish health and social care system, so that we're very importantly working together on that. Consistent with recent healthcare strategic initiatives, emphasise community so that everyone is maybe managed at a local level, so that you don't have to go and take up the positions of the consultants and the hospitals. You can be managed at a local primary level easier. Fantastic. And adopt an holistic approach. How many times already today have we heard that about an holistic approach, interdisciplinary, all these different words? Fantastic. It's a brilliant plan. Absolutely important. Vital to be done. Just before we go to the coffee break, I will say this.
Tantalising.
That was just a little tease for you. Importance of policy. If you have any health policy, it requires coordination between groups, departments, and medical systems. 25% of people have never seen a doctor about their pain. It was mentioned earlier about people who don't go, and they don't go in time, or they don't bother going to see doctors. We were talking about it over lunch as well. Job retention and return to work contingent on appropriate medical care as quickly as possible. You need to be seen early. You need to get that diagnosis so you can get the right treatment, so that you can continue working at the time, because if you're trying to return to work, that's the real difficulty. The risk of RMDs increases with ageing workforce. We all know that. That's what we have to deal with, so we have to be aware of it. And the impact of RMDs on work disability will intensify, because there's going to be more people of a working age who are going to be needing our support and our help. And the one final point is, we don't have to be 100% fit for work to be able to return to the workplace. We can have fit notes rather than sick notes. We can do things, we can be important. And just recently I started back into full-time employment, and it is the best thing that's happened to me in 8 years. And the thing about it is, nothing would be possible without being supported and being helped and having that. But none of it was policy. I had to do it. I did it. And I'm not doing that, saying that to blow my own trumpet. I'm just saying that if I can do it, loads of others can do it. But let's have a policy. Let's have something written down, and let's make it happen. The final thing I will say is, I was asked, can health policies help patients stay active in the employment sector? The simple answer is yes. But the important question is how. How do we do it? So, all policies require combined effort. All policies require drafting and sign-off. All policies require launching. And all policies require praise for coming up with them. But most important for patients, all policies require implementation. Thanks very much.
Thank you.